Good morning all and welcome to the National Myeloma Month series for May. Apologies for our delayed start this morning. For those of you who don't know me, my name is Emma and I will be your MC for our seminar today. In the spirit of reconciliation, Myeloma Australia acknowledges the traditional custodians of the country throughout Australia and their connections to land, sea and community. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples watching this seminar today. Our first seminar today will run for approximately 2 hours with a short break midway. We look forward to hearing from our 3 expert speakers who will each spend time answering your questions following their session. Please use the live Q&A chat box below to submit your questions. To join the chat, you first need to enter your name and then click join. If you don't wish to have your name displayed, you can just type anonymous instead. This year, you are also able to like questions other people have asked if you also want to hear the answer to that question. Any questions we don't get to answer today, we will endeavour to answer over the coming week. As always, these presentations will be recorded and saved for your viewing on our website at your convenience. We anticipate each recording will be available 1 week following the live seminar. Our theme for this year is wellness and possibility, and who better to explain what that means to our community than our very own Hayley Beer.
Thanks, Emma, and welcome everybody to our first National Myeloma Month event for this year, online event I should say. We have 3 online events, as Emma explained, happening throughout the month of May, and we also will have a variety of face-to-face events across the country, and I encourage you to check the calendar of events for an event near you. Adelaide kicked it off with their event on Wednesday, and from all accounts I hear it was a very successful gathering. I just wanted to bring your attention to 2 campaigns we have running this month for Myeloma Month. The first one being My Future, My Life, My Say. And that's to help increase the awareness and understanding of a new therapy that is being considered by the government committee that decides whether to fund new therapies, not the PBAC, but this one is MSAC. And at the moment, they're considering whether they should fund CAR T-cell therapy. So Myeloma Australia's Medical and Scientific Advisory Committee and us here at Myeloma Australia have had our say, but there's also an opportunity for you to have your say about how important it is that the government committee hear from you and why it's so important that they fund this new therapy. We will have in our next online seminar on the 17th of May a session about CAR T, but I'm sure it will come up multiple times throughout our seminars, as it's a very exciting new therapy that's currently funded in lymphoma, but not for myeloma yet. So we'll also be playing a video in the break that tells you a bit more about the campaign. And also, if you go to the front page of our website, you'll see a square tile called My Future, My Life, My Say. And if you click on that, it will explain to you how you can make a submission. Many of you do this already when there's a new drug up at the PBAC, so it's a similar process, just a different committee this time. And our second campaign, as Emma mentioned, is following our theme of wellbeing and possibility, and also a continuation on from last year's Myeloma Month campaign, 38 Mate, where we acknowledged some of the 38 people that are diagnosed with myeloma per week in Australia at the moment. And this year our campaign is called Joyful Moments. And we know that many of you are finding joy in your life in lots of different ways. And despite being diagnosed with myeloma, we're constantly inspired by all the things that you get out and about and do, or stay in and do, to find some joy and a distraction from the treatments or side effects or things that are happening to you. So we encourage people to send in to us their joyful moments, either by video or photo, to 38mate@myeloma.org.au, or you can email it to any of us at Myeloma Australia and it will get through to the campaign, because we want to share the inspiration that we see in you all the time with the rest of the myeloma community, and highlight all the great things that you're doing to find joy. For a bit of inspiration, I looked up to see what today's national or world days are, and I found it's World Pilates Day. So maybe you might want to do some Pilates. It's also National Lamb Roast Day and World Naked Gardening Day. So I don't advocate people do that in Victoria today. It's quite cold, but go for gold if that's what you want to do in the northern states. But we will censor those photos if that's what you send in to us. And also in February, we held some walks called 3.8, and it was amazing to see how many of the community got out and about and did their 3.8 kilometre walk, either with a group or by themselves. But unfortunately, in Queensland and parts of New South Wales, there was just too much. The floods, horrible floods were happening, so those events had to be postponed. But they are being held on the 29th of May. So again, go to the website for more details of those walks happening in Queensland and New South Wales. But it'd be great to see a sea of burgundy T-shirts walking again to finish off Myeloma Month. And I think the only thing for me to do now is to extend some thank yous. Firstly, to the team at Myeloma Australia for working so hard to pull all of these events together throughout the month. I'm very proud of how hard they've worked and for the excellent programs they've pulled together. All our wonderful speakers who give up their time and expertise to share their information with you, and I know they all love doing it, and we are very grateful for them for doing it too. And also, obviously, these events couldn't happen without support, and we're very grateful to our sponsors, Roche, Janssen, and our wonderful production company, CVP, who at the beginning of the pandemic, just before Myeloma Month in 2020, we weren't sure how we were going to continue our Myeloma Month education, and they came along and have been an enormous help getting us out to you despite lockdowns and pandemic conditions, and also have brought to us some new ways to share information, such as our podcast. So if you go to our website or any podcast platform, you can find My Conversations, which is our podcast series, and there are some more episodes soon to come out in My Conversations. So that's all from me. Thank you all very much for your attendance today, and I'll hand back to Emma. Thanks, Em.
Thank you so much, Hayley. I'll now introduce our first speaker, who will be presenting on a myeloma overview, a topic that is new to some and a wonderful refresher before diving in deeper for others. Dr. Angie Young completed her haematology training in South Australia and a clinical myeloma fellowship at the Royal Adelaide Hospital. She is working as a consultant haematologist at the Royal Adelaide Hospital and Lyell McEwen Hospital. Her areas of interest involve plasma cell dyscrasia, including myeloma and amyloidosis. Welcome, Angie.
Hello, good morning, everyone. Thank you for this opportunity to, I'd like to say give a speech, but I think, let's put it this way. Let's have a chat about what myeloma is, and we have a brief overview. We've got a few other speakers who will be covering on the treatment, on investigation. So I haven't really touched much on that, but let's try and let's go back to basics. So the first question is, what is myeloma? So myeloma is a cancer. It's a cancer involving the bone marrow. And in my next slide, you will see what the role of the bone marrow is. However, what happens in myeloma is that there are certain type of white cells which then become plasma cells, which are the immune system of the body. And in myeloma, there is an abnormal production, and some of these plasma cells which are abnormal are also increased in numbers. These abnormal cells can then deposit in the organs, such as the kidneys or in the bones, and they cause quite classic myeloma symptoms. Of course, not everyone presents the same way if they've been diagnosed with myeloma. We'll touch on a little bit about that later. So this is a slide, the most recent one that I could find on the statistics of myeloma in Australia. This is from 2021. For 2021, there has been an estimated 2,423 people diagnosed with myeloma, slightly more males than females. of all the cases of cancer that were diagnosed in 2021, myeloma accounted for 1.6%. In the number of deaths from myeloma in 2021, there were a total of 1,074. To put it into perspective, in terms, if we look at the mortality from cancer, so deaths from all sorts of cancer, the deaths from myeloma accounted for 2.2%. So in a way, when we look at the statistics, myeloma is actually not that common a cancer, but it can be quite debilitating. Now the chances, so this the next line, it says that you have in general, people have a 54% chance of surviving for at least 5 years with myeloma. But bear in mind that this particular number was from 2013 to 2017, and there's been many changes in the treatment of myeloma since then. I expect that the number, and I'm hoping that the number will be higher when we have our next round of statistics. So unfortunately, the pictures are not that clear, but what I have here on the left in the diagram is the numbers of a different type of cancers in Australia, diagnosis in Australia, and you can see that myeloma, which is highlighted in brown, is all the way to the end. So, you know, it is relatively common, but it's not one of the most common cancers diagnosed. This on the diagram on the right shows the survival. So it's a bit hard to see, but in general, it just says the rate of diagnosis, not survival, but the rate of diagnosis of myeloma from 2017 to 2021, and you can see that the numbers in general, the numbers of people diagnosed with myeloma has been slowly increasing. Yes. So what exactly is myeloma? What is a bone marrow? Now we have bones. This is our skeleton. And we know that the bones are hard. And that's, if you look at the middle diagram, there is a compact bone, and this is the cortex of the bone, and that's the hard calcium, the calcified part of the bone. But inside there is a spongy part, and this is the bone marrow, and the bone marrow makes our blood cells. It makes, if you look at the diagram on the right, the red cells. It makes white cells, which are the overall immune system of the body, and it makes platelets. I call the platelets the tiny frontline guts, the guts of your immune system. The platelets are the one, you know, if you cut yourself, I always say that the platelets are the ones that get activated first to try and activate all the proteins in your body to start healing that cut. Now, the white cells, there are different types of white cells. We have the lymphocytes. So we are a little bit focused on the first one. Lymphocytes are there are B lymphocytes, there are T lymphocytes. These are the antibodies of the system. We have the monocytes, which are also reactive white cells that try to defend the body against any infection. So they would try to eat, together with the neutrophil, which is the last one, they will try to eat up the bacteria, to try and eat up the invaders when you have an infection. The other two is eosinophils. Eosinophils are elevated when you have an allergic reaction. So they try to increase and say, no, we need to deal with it. So each of these different type of white cells play a different role in the immune system of the body. With myeloma, what we are focused on is on the lymphocyte, that particular lineage. So what happens in myeloma? A healthy bone marrow on the left would produce lymphocytes. B lymphocytes is what we are interested in. These B lymphocytes, some of the lymphocytes would then go on to differentiate into plasma cells. The plasma cells secrete antibodies, and these are the normal antibodies of the system. So if you've had, if you put it in very basic terms, if you've had a vaccination, these are the plasma cells. These your immune system recognizes that vaccine, and the plasma cells are the one that remembers the antigens here with this little Y-looking thing. They remember the exposure, and they're the ones that can then be primed and activate the immune system if you encounter the same infection again. In myeloma, this process goes a bit haywire. So the bone makes the B lymphocytes. Unfortunately, something triggers the bone marrow to then just make a particular type of plasma cells. So not just an all-round general, plasma cells secreting all sorts of antibodies. It just triggers one type of plasma cell to be produced in excess. And therefore, that particular plasma cells, there will be a lot of it. It will only be secreting one type of this antigen, so that Y thing. And because it's only one type, we call it a monoclonal protein. You may have heard that sometimes when you talk to your doctors. So that's what it means. It's a one type of that kind of antibody, and that's a monoclonal protein. On the right, that's just a little bit of a diagram of what a monoclonal protein looks like. So with the entire Y diagram, so in myeloma, sometimes the plasma cells would secrete this whole structure. We call that the monoclonal protein. Some people have a IgG, myeloma. Some people have an IgA myeloma, and that is just the type of the chain in light green, because some of the chains are IgG, some are IgA. So this helps to identify what type of monoclonal protein is secreted by the myeloma. In some cases of myeloma, it's not the entire structure that is secreted. These abnormal plasma cells make too much light chains. So light chains, and as a part of the structure, light chains are the dark blue aspects. So the little side chains here, they consist of kappa and lambda light chains. So some people's myeloma, the plasma cells only secrete this particular bit of the antigen. It can be kappa or lambda. And so for some of these myeloma classifications, we call them light chain myeloma. So it's still a similar process. It's still an abnormal production of the plasma cells in that process, but what that plasma cells are secreting is what, is the name that we give the myeloma. So it's IgG myeloma, or it's a kappa light chain myeloma. It's based on this antigen and what is being made in excess. Thus, a monoclonal, does an IgG myeloma behave differently from a light chain myeloma? Sometimes it does. Light chains, this particular bit, can cause quite a lot of kidney problems if they are too high. This is something that will be determined on a kidney biopsy. But in general, whether it's a whole entire antigen, whether it's a IgA, IgG myeloma, whether it's a light chain myeloma, we look for similar symptoms. So the common symptoms of myeloma, for an easy acronym to remember, is CRAB. Why CRAB? Myeloma can cause increased calcium in the blood. In quite severe cases, this can be associated with people who have got abnormal, very irregular, abnormal, almost at times life-threatening palpitations, because they just cause the heartbeat to go quite haywire. It can cause confusion if the calcium levels are too high. Some myelomas present with kidney problems. So the myeloma protein or the light chains actually deposit into the kidneys and affects the function of the kidneys. So, the kidneys filter out, the blood and removes a lot of toxins. And then that process is impaired if the whole kidney has got myeloma deposited in there. So people with kidney problems will be very lethargic. They may find that they may be going to the toilet quite often, or that their legs are quite swollen. They just seem to be puffy, putting up with fluid. And that's not explained by just a short period of just drinking too much water. This is something not right. And I have had patients tell me that they've gone up 2 or 3 shoe sizes, and that's how much the leg swelling has occurred. A stands for anemia, so a drop in the red cell count, fatigue, lethargy, just general muscle weakness can occur if the anemia is quite significant. The other difference for myeloma, and this is one of the more, I would say, not common, but it's a warning sign. So some people who have unexplained bone pain, backache, unexplained persistent, a scan has subsequently been done and it shows lytic lesions. So lytic lesions are a little bit different and quite different from osteoarthritis. So lytic lesions are described as little punched out lesions. So they are, if you look at a plain film, X-ray film, you can sometimes see little holes, and that's really quite abnormal. So when there are lytic lesions in any of the bones, one thing we always are aware of is, are we dealing with myeloma? Does this person have myeloma that's causing this pain? The other bone involvement that can occur is crush fractures. So when there's myeloma involvement in the bones can get quite frail, for want of a better word. They get quite frail, and that results, if there is some stress on the bone, that can result in just increased crush fractures. So crush fractures is when the bone vertebrae just becomes a bit more compressed. Sometimes in myeloma, some people may have plasma cells, the abnormal plasma cells, growing out of a normal bone, and that can be causing symptoms as well. Other features, which are non-CREB features of myeloma, people can have weight loss, they may have fevers. Some people with a very high protein, high plasma cell count, secreting a lot of protein, can have blurry vision because there's a lot of protein. It may affect the vision and can be a bit thick, blood can be a bit thick, or headaches as well. So this is what we call hyperviscosity syndrome. That's something that we have to be really careful about. So what investigations do we do for myeloma? There are a few. The first investigation we need to do would be blood tests. We do a blood test because we can look for anemia, remember low red cell count, and we can look for high calcium level, and we can check your kidney function and do that on a simple blood test. In addition, some blood tests will be sent to the lab to look for an amount of that monoclonal protein. Remember the abnormal plasma cells secreting the abnormal proteins here. So we can send that to the lab, and that's called serum protein electrophoresis. That test is not immediate. It doesn't come back the next day. It takes a few days to run, and in some labs, it may take 5 to 7 days for that result to come back. We can also check on the blood test how much circulating kappa and lambda light chains there are in the blood. And all this is to help us screen and check whether someone has myeloma. The other blood test that we like to do is a urine test. Light chains circulate. Sometimes light chains, if there's a lot of light chains from the myeloma, they can go into the kidneys, and the kidneys can secrete the light chains as well. It's useful and it's helpful to us to check whether there is any light chains that is in the urine. And these light chains are called Benz-Jones protein. I like to ask for a 24-hour urine collection. Sometimes I find that the secretion can be quite intermittent. So over 24 hours, I like to know how much Benz-Jones protein is being secreted. It also gives me the information. It also lets me know how much protein we are losing in 24 hours, if there are any, because it helps me know about exactly which part of the kidney is being affected by myeloma. On a side note, if someone is losing a lot of protein just because of the way the kidney function is being affected, one of the reasons why I like to do a 24-hour urine, especially during the workup phase, is because there could be a hint that we may also have coexisting amyloidosis. I'll touch on that a little bit later. So back to the investigations we do for myeloma. The third thing we do is we do a scan. Now, it is recommended, the MSET's come out with recent guidelines, it's recommended that we do a skeletal survey. What is a skeletal survey? It's basically imaging of the main bones of the body, so the spine, the skull, the long bones, the femur, the humerus, because myeloma tends to affect that, and the ribs as well. The recommendations for low-dose CT scan, because it's more sensitive, and it does help to pick up more myeloma. just bear in mind that unfortunately, what we call a CT skeletal survey is actually not Medicare reimbursed. And depending on your location where you stay, it may be that the only available modality is an X-ray skeletal survey. Now, it's not that the X-ray is not good. It's good. The CT is just a little bit more sensitive. But if we are working out for myeloma, we'll do whatever we need to. And a dedicated CT scan can then be ordered if we can't do a skeletal survey, if you have any symptoms. Some of the other tests that we can do for workup of myeloma will include MRI scans. For example, if someone has ongoing back pain, the CT scan of the spine did not pick up much, then we may request for an MRI scan. A PET scan, which is a kind of is a different scan. A PET scan is a nuclear medical scan, nuclear medicine scan, and what it does is a little bit of a tracer will be it will be given as an intravenous injection. But the PET scan looks at activity. It looks at the glucose metabolism, so like the sugars, how your body is using up some of the sugars. And in spots where there is active myeloma or active, for example, other types of cancer like lung cancer, that PET scan is useful to tell us which spots has got some activity going on. So it's just another way of us trying to diagnose whether the bones and is there any other parts of the body, not just the bones, that are affected by myeloma. Now, the PET scan for myeloma, again, is not a Medicare rebatable test. So access to this is quite limited. It's limited by hospitals, it's limited by the radiology department for where you're receiving treatment. And the final, I say a final test, we do a bone marrow biopsy. Now, some of my patients ask me, if I already have a blood test showing that there's a high monoclonal protein, if I have a blood test showing that I've got, really this amount of light chains and everything fits with correct, why do I still need to go through a bone marrow biopsy? I explain that the bone marrow biopsy is good. From the bone marrow samples, I can actually send for some tests that I can't get on the blood. What we look at on the bone marrow, or perhaps let's take a step back. What exactly is a bone marrow biopsy? So bearing in mind that some different centers do it a bit differently, I've just taken a very simple picture and I've copied this from the Royal Children's Hospital. But typically where we tend to do would be the posterior superior, this part of the pelvis, and it's the posterior part, so the back of the pelvis near the buttock cleft. We, patient will lie on the side, pull the knees up so that the bones are pushed backwards, and you can easily quite feel the bones there. The needle goes in. Remember, it goes into the soft part of the bone marrow between the heartbeats, and then the samples are taken out. It's usually, and I say usually because I'll jinx myself if I say that all the time, but it usually is a very straightforward procedure. It is local anesthetic can be given for that, and most patients will be fine the next day after. They might feel a bit of an ache, but it should be okay. What do we look at the bone marrow? So there are some samples that we take out and we look down under the microscope for the diagnosis. And I've got a little bit of a diagram on the right there. So the first thing we take out is we look at an aspirate. And what is an aspirate? When the needle is in, a little bit of the bone marrow, it looks like blood. So it's a test tube, it looks like blood. So it's taken out. It looks a bit like blood. We smear it on a slide, specimen A on the right side. And then we look at it under the microscope. There'll be little bone marrow bits there, and we can actually see the cells. As we smear it, the cells are spread out, and we can look at the cells in detail. It tells us how the white cells are looking, how the red cells are looking, whether there are an abnormal number of plasma cells. We can count it on the slide. It also helps us to see what the plasma cells actually look like. Do they look like normal plasma cells? Do they look like they are quite aggressive plasma cells where there's a lot of dividing activity going on? The second bone marrow sample that we take would be a trophine, what I call a trophine or core biopsy, where there's no sucking up of the tubes. What we do is that needle goes in, is very gently rotated, and then a piece of the bone marrow without much manipulation. That piece of bone marrow is taken out. We put it into something that helps to calcify, some solution helps to calcify, and then thin slices are then cut and put in a microscope. So that's put on a slide. So that's specimen B. And what happens with that is we then we cannot look at individual cells this way because that's for the aspirate part. But what it helps us is it looks at the architecture of how the bone marrow is organized. Does it look orderly? Is there normal, what I call bone marrow productions going on? Are there enough red cells? Are there platelets? So it looks at the architecture and tells me if there is a lot of myeloma that is overtaking all the other normal bone marrow function. So this also just gives us information. On the right side in specimen C is a clot section. So if we take out an aspirate, we put a little blob on a little dish, we allow it to clot, and then we do the same thing. We put it in something that helps it to dry out, calcify it, and we cut little slides. And then that also is another way of seeing the architecture. Now, some places tend not to do clot sections anymore, and some do. So I've just put it here because it's still something that is useful. Section D would be similar to that of a core biopsy. So it's really just looking at the architecture. Now, what are the samples from the bone marrow we do that is very different from just a blood sample? So we send off, when we take the aspirate, we send a little bit off to what I call the lymphocyte for immunophenotyping, or what we call lymphocyte surface markers. It helps us to see with these abnormal plasma cells, what kind of markers are expressed there. So myeloma cells sometimes express abnormal markers. All this is just a support to support the diagnosis of myeloma. Sometimes, interestingly, not common, but interestingly, with the lymphocyte surface markers, some people may also have a coexisting condition, a lymphoma, which is a totally different disease. And we actually find that on immunophenotyping. So any information, when it comes to myeloma, I say any information is good. Immunophenotyping is what we sent for. The last and most important, well, not most important, but it's really a very important feature for diagnosis is what I call the genetic test. So there is the karyotype. Now in humans, we have 46 chromosomes. Sometimes people have very aggressive myeloma where the plasma cells, the abnormal myeloma cells, have mutations that make the particular myeloma really aggressive. So whether they present with full-on crab features or whether the treatments that you give just don't work for a long time. So karyotype is another thing, or FISH. FISH is fluorescent in situ hybridization. So that's also another way of looking at the genetic mutations of the abnormal plasma cells. So this is important. And that's why we still do a bone marrow biopsy or this test. We cannot do it just on blood. So this bone marrow helps us in the diagnosis, supports us in the diagnosis, and it helps us in prognosis as well. Sorry, I was just going to go back a slide. Now, let's go to the next slide. So we have normal B cell production in the top line. That's a normal bone marrow. Remember, we have the lymphocytes into normal plasma cells with a full range of antibodies, and that's normal. In myeloma, at the bottom one, we have abnormal plasma cells, quite a lot of plasma cells. They are secreting a monoclonal antibody, and these plasma cells cause the end organ damage. So they cause those crab features that I mentioned with high calcium, anemia, bone lesions, kidney problems. Sometimes though, you have some people have been diagnosed with this in-between phase, what we call MGUS. So MGUS stands for monoclonal gammopathy of uncertain significance, quite a long word. What it means is there are some plasma cells in there. They are secreting a monoclonal protein, but not at a high level and not at a high number. So they're kind of like, I like to call it pre-cancerous, pre-malignant. So there are enough plasma cells there. It's not enough to cause myeloma, but it's there. There is no crack features. There is no bone lesions. The calcium level is normal, no anemia, and kidneys are normal. For people with MGUS, there is an increased risk of fractures. There can be changes in the bone density, but there is no crack features. So I will touch a little bit on this about treatment later, but why is MGUS important? I think MGUS can be common. It can be diagnosed in up to 5 to 8% of the general population above the age of 75. So it's something that can be common as we get older. It doesn't mean it doesn't lead to myeloma, but with MGUS, our GPs and for general health, we should be monitoring the monoclonal protein once or twice a year to keep an eye on things. So remember, I've talked about the karyotype, the diagnosis, the genetics. We use the revised international staging system, the RISS, to stage myeloma. This is based on certain criteria. So we look at the albumin, which is the protein production in the blood. We look at LDH, lactate dehydrogenase, and that is more of a marker of cell turnover in the blood. And the beta-2 microglobulin, which is a protein on B cells and plasma cells. So if the beta-2 microglobulin is high, generally it does mean that the burden of myeloma is high. Just a side note that the beta-2 microglobulin is filtered by the kidneys. So if there's a problem with the kidneys, it's not going to filter it well, the beta-2 microglobulin is going to be elevated anyway. So these are the 3 markers that are based on blood tests. And then the next criteria will be whether are there any abnormal genetic mutations found in the bone marrow cells, which we usually diagnose on a bone marrow biopsy. There are some genetic mutations that are higher risk than others. So why we stage now? Whether we are stage 1 or 2 or 3, it does not really make a significant difference in the treatment that we give. All treatment for myeloma is based on what we can get on PBS. I like to know what the prognosis is in general, because I do sometimes it can change the treatment. We may recommend that if someone is young and they have a higher risk myeloma, that some hematologists may suggest having 2 transplants instead of 1 transplant. I'm not going to cover the treatment part because I think someone else is going to talk about treatment. But in general, when it comes to myeloma and any type of condition, the way I think is as much information as I can get is better. So I like to know what the staging is. Now, you may have heard these terms. Some people, it's not just myeloma. Now, you may have heard about solitary plasmacytoma. Now, what is that? It is a similar condition, except that those abnormal plasma cells are not found in the bone marrow. There are no typical crack features. What happens is some of these abnormal plasma cells just found in one place, and they cause an abnormal growth and a normal lump there, and we cannot find evidence of myeloma anywhere else. So this is what we call solitary plasmacytoma. It can happen in some people just in the spine, in a rib, in one particular spot of the body. Smoldering myeloma. Smoldering myeloma is when people have quite a moderate number of abnormal plasma cells on the bone marrow or on the monoclonal protein, but there are no crack features. So there's no calcium, no kidney, no anemia or bone lesions on the scan to diagnose that. So we call that smoldering because they may develop myeloma soon, but they just haven't. Another condition is non-secretory myeloma. So patients with this, they do have abnormal plasma cells. And I'm just going to see if I can bring up this. So on the right side in this diagram, they have the abnormal plasma cells here. That's causing the typical features of myeloma. There can be bone lesions, high calcium, anemia, or kidney problems. However, those plasma cells do not secrete a monoclonal protein. They don't secrete light chains as well. So on the blood test, they have like no paraprotein or no light chains, but they have myeloma because when we do the bone marrow, we actually find the plasma cells. The next item is plasma cell leukemia. That is when so usually for myeloma, all these abnormal plasma cells are found in the bone marrow or in spots where myeloma affects. So if I have, if someone's got a a lytic lesion in the bone, we do a biopsy of that and we can find plasma cells there. What happens in plasma cell leukemia is when there is circulating abnormal plasma cells in the blood. It is a sign either of aggressive disease, it is a sign of end-stage myeloma. In some people, they have got quite aggressive disease. This is how we diagnose myeloma, is when they have a blood test and we see abnormal myeloma cells in the blood. Now, there are some other conditions that can be associated with this similar kind of, you talk about plasma cells, but it's actually not myeloma. Sorry, just hold on. So it's actually not myeloma. POEM syndrome. So POEM syndrome is a disease, different disease entity. There is still a monoclonal protein there, but in POEM syndrome, they manifest quite differently. They've got neuropathy, nerve problems. They might have bigger, some organs that have been affected, like a big spleen, for example. They might have problems with diabetes or thyroid and skin changes as well. So POEMS is even though there's a monoclonal protein, it is a different disease from myeloma. I'd like to talk a little bit about AL amyloidosis, something I'm interested in, but it can coexist with myeloma. And what is AL amyloidosis? Amyloid's an abnormal protein. It's an abnormally folded protein. And in some cases, the amyloid itself is being driven by the abnormal plasma cells in myeloma. So it is said that in 10% of patients with myeloma, there can be amyloid as well. It's just that it can be hard to find. So AL amyloidosis, different disease, but can be driven by that same abnormal plasma cell. The final one is lymphoplasmacytic lymphoma. There are abnormal plasma cells in the bone marrow, but this part where the abnormality happens is somewhere between the B cell and the plasma cell. So the differentiation bit, the part where the abnormal increase happens, is actually slightly earlier than the plasma cell stage. And this actually causes more of a lymphoma than a myeloma. So people do ask, can myeloma be inherited? My uncle has myeloma. Is this something in the genes? Myeloma is not considered a hereditary disease. It's not something that you have in the genes that you pass down. But the risk of developing myeloma does increase if you have first-degree relatives. So your parents, your siblings, if they have myeloma, then your risk of developing myeloma increases. If you've been diagnosed with prior MGUS, remember the extra protein, but the protein that doesn't cause the CREB features. If someone has had a plasmacytoma before, where there's only one spot where myeloma is found, then there's a risk of developing overall myeloma. If you are of African descent, yes, there is an increased incidence of myeloma and if you're of African descent. So the African Americans in America, there's a big population of myeloma being diagnosed there. And if there's some prior exposure to radiation or benzene, seems to trigger the abnormal plasma cell population. I just want to put a note here that if there's prior exposure to radiation and benzene, it can also lead to an increased risk of other types of cancers. So not just myeloma itself. Just very quickly, treatment for newly diagnosed symptomatic myeloma. So who should start treatment for myeloma? Anyone who's symptomatic with CREB features should start treatment. What we are aiming with treatment is we want control of the myeloma so that we don't get further involvement. Our organs are stable, so it does not deteriorate. How about people with what we call, smoldering myeloma? Some patients say, look, I've got smoldering, I've got a big number of plasma cells, but why are you not treating me yet? Well, if you have a high number of plasma cells, abnormal plasma cells in the bone marrow, you don't have correct features. However, there is a criteria called the biomarkers of malignancy. So if the bone marrow plasma cells are quite high, they're more than 60% of the entire bone marrow. If you have light chains and the abnormal light chains over the normal light chain, the ratio is above 100, or on the MRI, which is a much more sensitive test, we can find more than one spot, then we consider this as, we should consider this as myeloma, and anyone with those criteria should be treated as though they have symptomatic myeloma. How about the other conditions I mentioned? So solitary plasmacytoma, remember just that one spot, usually radiation therapy is the main treatment. There will be a few fractions of radiotherapy given and then monitoring after that. For MGUS, small number of monoclonal protein or small amount of monoclonal protein, no correct features, monitoring should be the mainstay of treatment. There's no evidence to say that treating MGUS earlier makes a difference in the outcome. Who should monitor MGUS? And I think this is quite a varied opinions here. If you have a good GP who is very on the ball, who's happy to monitor, I would say a good GP should be able to monitor MGUS with the blood test as well. And at any sign or any development of symptoms, scans can be organized. Now, in smoldering myeloma, where there is a high number of plasma cells in the bone marrow to consider myeloma, but you don't have correct features, there are a couple of ways we can do depending on access to treatment. So the first mainstay is there's still no evidence that smoldering myeloma we should be treating everyone up front. So monitoring still remains the main way to go to proceed with smoldering myeloma. But there is some criteria which has been come up recently by the Mayo Clinic. They call it the 220-20 criteria, where some features, if there's a high enough number of monoclonal protein and high enough number of bone marrow plasma cells, that there has a higher risk of progressing to myeloma. So some centers and some hematologists would consider treatment in people who fulfill the high-risk criteria. That's not a widely adopted approach. It's not a standardized approach. So I would say we will have to discuss this with your hematologist. There could be other features that we're not aware of. The other third option for smoldering myeloma that I encourage would be clinical trials. We don't know enough about smoldering myeloma. So enrolling into a clinical trial would be a good way to help future people know and help the clinicians know exactly what we should be doing with smoldering myeloma. In general, the treatment for newly diagnosed myeloma in general would be we give a short course of what I call induction therapy. If patients are appropriate, then we may consider an autologous stem cell transplant followed by maintenance therapy. If someone's a little bit on the older side of age and has heart problems and is quite frail, then autologous stem cell transplant is obviously not the best option. Induction therapy, appropriate induction therapy, plus or minus maintenance, ongoing therapy can also be considered. Radiotherapy or surgery also may be necessary if the myeloma affects a bone site, for example, in the hip, where there is an impending risk of fracture, then surgery may be necessary to prevent fractures prior to starting therapy. All this, and also I should mention again, clinical trials. Now, all this should be considered and discussed together with your treating hematologist. Everyone is different. It's not a guideline ABCD that we follow. Treatment is targeted and it's aimed at your myeloma, your age, your comorbidities, and how you go about doing this. So we should discuss this with your treating hematologist. If there are clinical trials available, I also say please consider a clinical trial. Clinical trials do help us find out more about treatment options as well. Now, common question I get, can myeloma be cured? Unfortunately, myeloma is not a curable cancer yet. A lot of studies are being done. A lot of research is being done. We've made many progress in the past, a lot of progress in the past 10 over years of treatment. So watch this space. I believe that one day we can say, yes, myeloma can be cured, just not yet. Our main aims of treatment are to control. We want remission, whether the protein is down, there's not much production of abnormal plasma cells. I think I'm running out of time, so I'm just going to quickly cover this bit about treatment because I believe it will be covered by another presenter later. But as of May of this year, there are a few PBS funded treatment for induction. So the newly diagnosed myeloma, there's few new PBS funded treatment and combinations as well. The common combination, all this will be tailored and adjusted to you and whatever your general health is like. So treatment is always individualized, it's not a standard treatment. Autologous stem cell transplant, as I mentioned, I'm not going to cover. I think I'm running out of time. So for fitness for the transplant, we need to be assessed. Yes, discuss this with your treating hematologist. I'm happy to answer any questions, and if there are any questions, happy for the Myeloma Australia to forward them to me. But for a general slide here is just what is available on PBS for relapsed myeloma, and this changes all the time. Again, like I said, many changes for the past 10 years. We have so much more available now that we didn't used to. My slide clicker is not working. Yeah, thank you. Hold on. So what are the treatments in relapsed myeloma available? We have clinical trials now. We have a lot of new therapies. You've heard a lot about CAR T therapy. At the moment, that's available on clinical trials in only some centers. There are antibodies and very different things now. And I think the future of myeloma, the overall survival of people by myeloma is looking very, very promising. So supportive care, I'm going to take 2 minutes because I think this is very important. So what is important in myeloma, apart from the treatment, we need to make sure, and I always like to talk, we need to make sure that we can try and aim for good quality of life. If there's pain, bone pain, pain relief is essential. Radiotherapy may be useful for pain relief. If someone's got a lot of bone involvement, radiotherapy you can get a quicker response just from a little bit of radiotherapy. And also that can help with some pain relief at the site. Surgery if appropriate. If bone protection, another topic that's close to my heart. Now, what we need to do in myeloma is even in people who haven't had any bone lesions, there are in the bone microenvironment a lot of myeloma affected activity going on. There's increased bone destruction. So we need to look at how we're going to prevent further bone damage. So bisphosphonates, you may have heard of this, Zometa, palmitoic acid, that's important to try and slow down the bone turnover. It's like to slow down the destruction of the bone. And that's something that should be considered in everyone with myeloma, even if they didn't have any scan evidence of bone disease. The problem, I'll do that next page. But also the other issue with myeloma is there's a risk of infection just because you had myeloma already. Remember the bone marrow? Plasma cells secrete antibodies, but the normal antibodies from the normal plasma cells, that part can be a little bit subdued and suppressed because the bone marrow is producing a lot of abnormal myeloma cells. So some patients are at risk of infection, vaccination. Be careful going out. We have COVID now. That has been quite a difficult situation for all of us. I would say just keep safe, keep up with your vaccinations, discuss it with your treating hematologist. There are also treatment-related risks, so infections, high sugars from steroids, gastritis, if you are high dose steroids, that's right. It can cause some gastric erosion, so make sure that you've got some adequate protection for that. And of course, one important thing, clotting risk. Some of our myeloma medications and having myeloma itself can sometimes not sometimes, but it does lead to an increased risk of clots. So, make sure that we think about that and there's some adequate plan in place to prevent this. always make sure before we start bisphosphonates, Zometa or palmidronic acid, always make sure that you keep up with your dentist's regular dental review. There is a rare condition called osteonecrosis of the jaw, where there's an infection in the jawbone here, exposed bone, that is really very difficult to treat. And because bone is not a soft tissue that heals, that makes it, once you have ONJ, and if it's a severe one, there can be ongoing problems with that. One of the ways of preventing this is to have a good dental review. If we can, before treating with bisphosphonates. If not, because if there's an emergency, then a dental review after the first dose, if we can. Dental health would be the mainstay of prevention of all osteonecrosis of the jaw. So a few resources, and I found this to be quite useful for the local resources. There's Myeloma Australia, the Leukemia Foundation, and the Cancer Council website. There are a few overseas resources, but I think these would be the main ones that we should refer to because they're quite good. Thank you.
Thank you so much, Angie, for that very in-depth overview. We really appreciate your time. We do have a couple of questions. The first one from Jonine. How high can your paraprotein levels go before it causes damage?
It doesn't need to go high before it causes damage. Remember that slide I showed with the plasma cells and the antigens being secreted? Sometimes you can even just have a low paraprotein of 8 or 10, and you have a lot of features of myeloma, bone features or kidney features. Remember, there was a slide that I said about non-secretory myeloma, where sometimes the plasma cells don't secrete the paraprotein. So, and yet people still get the full crab feature. So you actually don't, the number doesn't tell you that you're safe or not safe from you know, for having features of myeloma. It's more related to the scans, what the numbers are doing, and exactly what's happening. It's hard. It's not a one-size-fits-all kind of thing. And that makes myeloma just a little bit more tricky to explain because everyone's a little bit different.
Yeah. And we have time for one last question. I have smoldering myeloma. Is there anything I can do to prevent it from transforming into multiple myeloma?
I get that question a fair bit. The short answer is no. There is unfortunately not much to do to prevent transformation to myeloma. But what I always say can be done would be keep healthy, keep fit, you know, make sure that the dental review is fine, because when the time comes for treatment, and we don't know when that will happen, but when the time comes for treatment, you are as prepared and as fit as possible to have the best outcome from treatment.
Thank you so much again, Angie, for your time today, especially taking time out on a weekend to be with us here and give us a very thorough myeloma overview. We're going to cut to a short break now where we'll play 2 of our new campaign videos, and just take your time to grab a cuppa, go to the bathroom, and we'll see you back here in about 5 minutes. Thanks again, Angie.
Hi everyone. Last year we introduced you to 38 Mate, an awareness campaign that shone a light on myeloma and the 38 Australians diagnosed each week. This year I want to tell you about our new campaign, Joyful Moments. This campaign celebrates all the wonderful things our 38 mates, their carers and our community enjoy. Maybe it's a new hobby you've taken up or an old passion that you've found a new way to enjoy. We'd love for you to share your joy with our community. Maybe you love fishing, swimming, bushwalking, playing music, or something completely different. I've been with Myeloma Australia for a number of years now, and over that time I've met so many wonderful Australians who love doing so many different things. We know that being diagnosed with myeloma can have a significant impact on your life, making it difficult to do things you used to do. But sometimes it's possible to do the things you enjoy, just in a slightly different way. So while we spend a lot of time talking with you about myeloma and all that goes with adapting your life to living with it, We want to take some time out to celebrate all the amazing things that you do when you are being you. Because that's really the goal of everything we do, to support you to spend more time being you. Joyful Moments also fits perfectly with our focus for Myeloma Awareness Month. In May, we will have seminars focused on wellbeing and possibility, reflecting the hope that new treatment advances are bringing in myeloma. We know that at the heart of wellbeing is doing more of what you enjoy and what makes you feel happy. Sharing what makes you feel good may also inspire others to take up a similar interest and spread the joy further. So over the next few weeks, we want to hear from you, your family and friends. Just complete the sentence, I'm a 38 mate and I love, or I care for a 38 mate and I love. And send a photo or video of you doing whatever it is you love to do. Simply email 38mate@myeloma.org.au. We'll then post your pictures and videos sharing joyful moments across the myeloma and wider community. We really look forward to seeing your photos and videos. Thank you.
seminar. I will now introduce our second speaker, who will be presenting on interpreting tests and investigations, a topic that is very useful in helping you to understand your results of your blood tests and scans and their role in diagnosing and monitoring myeloma. We have with us today Dr. Dipti Talaulika, who is a clinical and laboratory hematologist at Canberra Hospital with a clinical and research interest in lymphoma and myeloma. She is an associate professor at the Australian National University. She sits on the Medical and Scientific Advisory Group of Myeloma Australia and has published several myeloma guidelines. Welcome, Dipti.
Thank you very much, Emma. I'll just highlight the slides, then we can get started. There we go. I hope everyone can see the slides well. Thank you for having me, Myeloma Australia, and welcome to everyone who's on the talk. So I have been tasked today with telling you about some of the investigations that are performed for both diagnosis and monitoring of multiple myeloma. I thought I would start with a case. I find that a really good way to try and illustrate how patients would be managed. So Mrs. MM, she's a 72-year-old lady who presents to her general practitioner or GP for routine bloods. She's got no symptoms at all. ESR, which is an inflammatory marker, is elevated in her case, and she has a liver function test done as part of her routine investigations, and that shows that there is an increase in globulins. So normally, as part of liver function tests, you get two protein components that are listed. One is albumin and one is globulin. So the globulins in her case were increased. Now the GPs know that when you get elevated globulins, it can be a whole range of different conditions, including multiple myeloma. So normally they will order serum immunoglobulins. So they will check your IgG, IgA, and IgM levels. So in her case, she ends up having an elevated or high total IgG level. And when the laboratory put out the result for that, they suggested running additional protein studies. So there's a whole range of different protein studies that we can do, starting from a simple liver function test to quite complicated tests, which I will walk you through. And they also suggest referral to a hematologist. So Mrs. MM ends up going to a hematologist who then requests a whole range of additional investigations. Now, one of the first tests that's often done is a full blood count and blood film. So in this patient, the full blood count showed a low hemoglobin or anemia. And you may have heard by now that CRAB or hypercalcemia, renal failure, anemia, and bony disease, they are the hallmarks of end organ damage in multiple myeloma. So she certainly seems to have that feature there. What I've got here on the left is a picture of her of her blood film. So from the blood sample that is collected, we make a slide, make a smear out of it, and then look at it under the microscope. So these are the red cells in the background, these donut-shaped cells. You've got a tiny platelet there, and you've got a white cell. This, in fact, is a plasma cell, very hard to see in the circulation, but she certainly seems to have one cell, at least, that's visible on this field. Now, normally, the red cells tend to be quite nicely separated from each other, but in this case, you can see that they are stacked on top of each other, and that's caused by the high protein that patients with multiple myeloma tend to have. So it just makes the red cells a bit sticky, and they tend to stack up on each other, and that's known as rouleau. The other thing that we often tend to see is if you just hold the slide up to light, you will find that there's a blue tinge to the film, and that's again caused by the high protein in the blood. So that's what we see on the full blood count and on the blood film. Now, the other two cardinal features, renal failure and hypercalcemia, can be assessed through basic biochemistry. So patients will have calcium levels checked. In her case, the calcium level was normal, but she did have a bit of renal dysfunction. So creatinine was high and eGFR was low. Now that could be because of other reasons as well. And I haven't told you yet, but Mrs. MM also has diabetes. So she has a bit of renal dysfunction because of that. So not all of these features are due to multiple myeloma, and hematologists have to sort of put the puzzle together by combining a number of investigations to decide whether a patient has multiple myeloma or not. Some of the investigations that really help us, so all of these so far that we've looked at are quite non-specific, but the specific investigations that help us to make a diagnosis are one, a bone marrow biopsy. So Mrs. MM went on to have a bone marrow biopsy, and on the right-hand side, you can see a picture of the bone marrow aspirate there, and it shows lots of plasma cells. So plasma cells are the key malignant cell in multiple myeloma. And normally in the bone marrow, all of us have plasma cells. We have them in usually less than 5% in the bone marrow, and they produce antibodies which help us, which protect us from infection. So we need those plasma cells there. But in multiple myeloma, they become malignant, so they're quite abnormal looking, and I'll walk you through that in a minute. But also they are increased in number. So in patients with smoldering and multiple myeloma, you would find at least 10% plasma cells in the bone marrow. In MGUS, you can have less than 10% plasma cells. So this is what the plasma cells look like. They've got a nucleus that's quite eccentric. So it sits, instead of in the center of the cell, it's sitting on one side of the cell. You've got this really blue cytoplasm, and you have this clearing around the nucleus, which is again quite characteristic of plasma cells. Now, how do we know that these are malignant? So some of them have immature features. So there's a clearing in the nucleus here that you can see. That's a nucleolus, tells me it's an immature plasma cell. And here you can see a binucleate form as well. So these are some of the features. So we look at the numbers, but we also look at the morphology of the plasma cells. Now, the other thing that really helps the hematologist besides the bone marrow is actually looking at additional protein studies. So in this patient, we established that she had high globulins on liver function test, and we also established that she had high IgG. Let's look at how we actually try and find the abnormal protein in patients with multiple myeloma. So we tend to do an investigation called serum protein electrophoresis, where we take a bit of the patient's plasma and we subject it to an electric charge. So you can see a picture there on the top panel under A. And based on the size and the charge of the different proteins, they will separate out after a period of time. So on the top panel, you can see albumin there, which is present in the most amount, and that's also demonstrated with quite a large peak. You then have your alpha-1, alpha-2, beta, and gamma globulins. If you look at the gamma globulins at the top, they are seen as a smear or a smudge. So that's a nice, normal polyclonal globulin smear. If you look at the one below, you can see that there's quite a dark band, and that's shown with another peak in the gamma globulin region. So that's an abnormal protein, the paraprotein or the M protein, that's quite characteristic of multiple myeloma. Now these bands, they tend to get measured as a percentage of the densitometry trace, and they are converted to gram per liter by multiplying it with the total protein of the sample. So that's how you get a numerical result. Now each laboratory, some of you might have had the experience of having blood tests performed at different laboratories, and you'll find that there's sometimes a bit of variation between laboratories. So each laboratory has a different, they might use a different method, they might have they might have different instruments. So each laboratory needs to establish its own reference intervals. So I've got the reference intervals here. So gamma globulins tend to be between 7 to 16 grams. And in this patient, you can see that it's obviously quite increased. So maybe it's sitting around 40 grams or so. And then we said that this patient had an IgG paraprotein or increased IgG protein. So that's because of the abnormal protein or the M protein. So let's look at how that is measured. So we've established now that this patient has a high gamma globulin. Now we need to type it, right? And we have a suspicion that it's an IgG because the total IgG is elevated. So now we would run what is known as immunofixation. It's all quite complicated. But basically, we have these different lanes. And on each lane, we would use an antibody against a specific type of protein. So IgG, IgA, IgM, kappa, and lambda. And we add a dye there. And then we run the patient's plasma on it. So you can see in this case, it's shown up quite nicely as an IgG lambda paraprotein. So that's how we know what the type of the paraprotein is. Now, so far what we have talked about is measurement of the intact immunoglobulin. So immunoglobulin is nothing other than antibodies, which we all have, but we have a mix of antibodies or polyclonal antibodies that help us fight infection. In patients with multiple myeloma, it's the same type of protein. So it's the M protein or the paraprotein that we need to look for. So far we've looked at the intact immunoglobulin, but all of these patients also secrete free light chains. So that's just this component here of the intact immunoglobulin. And because it's much smaller, it's a lot more sensitive in measuring disease burden in multiple myeloma. So most hematologists will also do a serum free light chain analysis. Now I apologize, the slides looks quite complicated, but I'll walk you through it. So on the x-axis, you've got kappa light chains. On the y-axis, you've got lambda light chains. Right? In the middle here, you've got a normal patient. So any of us, if we have a blood test done, you will find that the kappa and the lambda are quite balanced and they sit in the middle in quite low quantities. If someone has kidney failure, it's still a balanced production of kappa and lambda light chains, but it is present in higher quantities. Now, this is the case because free light chains normally get excreted by the kidney. So when you have kidney failure, you tend to have increased amounts of both kappa and lambda light chains, but it's fairly balanced. Now, in patients who have kappa multiple myeloma or lambda multiple myeloma, you can get a predominance of kappa light chains or lambda light chains. Now, this is particularly important in measuring response because often the intact immunoglobulin or the paraprotein will get depleted first, but the free light chains will still remain. So this is how we make a distinction between complete response and stringent complete response. So when the free light chains are normal, then you say that the patient has achieved a stringent complete response. Overall, serum free light chains are reported as kappa light chains, lambda light chains, and a ratio. So the ratio is quite important because it helps us to diagnose multiple myeloma. Serum free light chains are also quite important in diagnosing a condition as light chain multiple myeloma. So in some patients, you will not see an intact immunoglobulin at all, and you might only have light chains. So this is required as part of the diagnostic workup. So that is all I had on the protein studies. We've talked about the bone marrow. So the only other thing that is left to talk about in terms of investigations is bony disease. So we all know that multiple myeloma causes lytic lesions. And previously, we used a skeletal survey using X-rays. So we did X-rays on 4 regions of the body. And here you can see lytic lesions in the skull, in the pelvis, and in the long bones of the leg. But now we use more sensitive methods like CT scan, which you can see on the top left corner there, and a lytic lesion highlighted quite clearly. So we do a whole body CT scan, but we can also do an MRI, whole body MRI, or a PET CT scan. And depending on what you're looking for, and more importantly, what is reimbursed, different investigations tend to be used. I think across Australia now, whole body low dose CT is quite widely available. So I suspect a lot of patients on the call today would have had that done. But if it is possible, MRI and PET scan can be a bit more sensitive. So just to summarize, patients with multiple myeloma tend to have a full blood count performed, EUC, which is looking at renal function, liver function tests, which will tell you if the globulins are elevated, and calcium levels. In terms of the specific protein tests, we do serum immunoglobulins, so looking at IgG, IgA, and IgM levels. We then do serum electrophoresis to look for the M band or the paraprotein. And then we use immunofixation to type the paraprotein to tell us whether it's IgG or an IgA, and to tell us whether it's kappa or lambda. Serum free light chain is done at diagnosis and often at monitoring, but it may be used less frequently than the other investigations. Bone marrow biopsy is done at diagnosis, and scans for bone disease are again done at diagnosis. Now, when are all these investigations used? So certainly we want a full workup at diagnosis, and mostly it's blood tests, including all the protein studies at follow-up, usually every 3 to 6 months. Might be a bit more frequent if you are on treatment, but generally the IgG takes about 3 or 4 weeks to regenerate. So there's no point in doing the investigations more frequently. And if relapse is suspected, then again, you might end up having the full workup done. So that was all I had. Thank you very much for listening. And if there are any questions, I'm very happy to take those.
Thank you so much for that presentation, Dipti. We do have one question from George. I have heard the term MRD negative. What does this mean?
Yeah. Thank you very much for that. So minimal residual disease is coming in quite a big way in the evaluation of multiple myeloma, and I haven't really covered that at all today. So we can use a number of different investigations to measure MRD. MRD basically means that even when you don't see any disease, obviously, we know that myeloma is an incurable disease. So there's bound to be small amounts of myeloma still present in the body. And there's different ways of looking at it. So you can use flow cytometry. You need to count a lot more cells. That's done on the bone marrow. And you can also use next generation sequencing, a much more sensitive method to look for MRD negativity. Basically, after treatment, if a patient has achieved MRD negativity, it means that they've had a very good response to treatment. And we expect those patients to do better in the long run and have recurrence of the disease after a longer period of time than patients who are MRD positive.
Thank you. Thank you again, Dipti, for joining us today. Again, especially taking time out of your weekend to be with us here and share your knowledge. We don't have any further questions, so we might introduce our third speaker. It's a pleasure for me to introduce our final speaker, who will be presenting on travel and myeloma, a topic we hear brought up again and again at our support groups and on our telephone support line. Jo joined Myeloma Australia in 2008 and is a senior specialist myeloma nurse. She has worked and volunteered for Myeloma Australia for over 12 years. Jo has over 30 years of experience in a range of haematology nursing roles, from clinical and coordination to research. Based in Adelaide, Jo also works for Cancer Council Services at Royal Adelaide Hospital as a myeloma research nurse. Jo is a mum to 3 adult children, loves the family shack on the water, enjoys gardening, bushwalking and camping, and she also enjoys being creative through drawing and painting. Welcome, Jo.
Thank you, Emma. It's lovely to be here this morning, and I'd love to thank our previous 2 speakers who have given us that bread and butter overview of myeloma. I'd just like to change tack now. We have a focus of wellbeing for our seminars this month, or for 2022, and I think to go travelling is something that focusing on is going to give us the opportunity to look at what is our potential and opportunity to achieve. So today I'd like to look at things we should be considering when we're planning travel, in particular what's related to myeloma. I'm just trying to find the clicker for changing the slides. Just not sure how that's going to work. So there are some various things we need to consider, and that's what I'm going to run through. I can't see the clicker for how to change these slides. Oh, thank you. So planning a holiday will involve more thought and consideration to take into account what you can and can't do with the myeloma diagnosis, but it won't stop you from being able to travel, especially now we're able to open up and travel more after the pandemic. So next slide, please. When you're planning a holiday, it's really important to discuss the travel plans with your doctor before you start to make any bookings, to ensure that the plans you're making are appropriate for your myeloma situation at that time. You can discuss that with your doctor, and then once you've got something that's approved, you know how long you're going to be away for, you can ask your doctor to write enough scripts that cover your regular medications for the whole trip, but also to add some extra in case of delays or loss of tablets or medication. And just to this point, the common oral medications for myeloma, thalidomide, lenalidomide, and pomalidomide, have recently been made available on a 3-month supply for men and women of non-childbearing age. So 3 months may be available to you if your haematologist feels that your myeloma is stable enough for you to be away for an extended period of time. Other things you'll need to discuss regarding medications are a range of supportive care and things like antibiotics in case you get an infection. So scripts can be written and filled for you to take those with you. Next slide, please. So also discussing with your treating team, you'll need to request a letter with a brief history of your myeloma, when it was diagnosed, what treatment you've had, and what the responses have been, including what your current situation is. And that will be helpful if you need to get medical attention whilst you're away. And this letter should include contact details for your treating team, especially your haematologist, by phone and email. It'll be important for any doctor overseas to be able to discuss with your haematologist any further queries or questions they may have. Also, when you're planning your itinerary, it's a really good idea to have contacts for myeloma specialists who are at destinations that you're traveling to, especially if you're going to be there for any length of time. You'll also need to discuss what vaccines you can have that are appropriate for your destination, and what are appropriate for you to have. So some of them are live vaccines and are not appropriate for immunosuppressed people to have. So you'll have to discuss that with your doctor. Also, make sure that your COVID vaccinations and your current flu vaccination are up to date before you travel. Some insurance companies will require a letter from your hematologist to make sure that you are fit, or to state that you are fit to travel. So that's another document to request. Next slide, please. So looking at international travel, that'll be the main focus of the rest of this talk. Next slide, please. There are 11 countries that have reciprocal healthcare agreements with Australia, and they tie into our Medicare program. But each have their own conditions to meet. This can be researched on the Services Australia website, and they'll have the current listing of countries that are available under this scheme. So that means that travel insurance may not be required. Travel insurance for your myeloma may not be required in those countries. And also, if you're just travelling within Australia, domestic travel medical expenses are usually covered by your private health insurance and Medicare. So claims of private insurance are made first, and then Medicare cover the gap. So check with your private health insurance company, if you have it, exactly what they'll cover for you while you're away. Also discuss with your treating team how stable your myeloma is. Because if your myeloma is well controlled and your holiday is only for a few weeks, your risk and insurance requirement for covering myeloma complications may be quite low. And in fact, you may not need to cover it. So myeloma can be excluded under cheaper travel insurance policies, but they'll still cover unforeseen health issues. Next slide, please. So looking at travel insurance for pre-existing medical conditions, and this is where myeloma sits. It needs its own separate declaration and cover. Now, under Australian law, insurance contact regulations define pre-existing medical conditions as those that exist 6 months before the contract was entered into and continues after that contract was signed. But unfortunately, insurers do get around this 6-month rule by specifying in their product disclosure statements exclusion or limitation around this point. So you might find that insurers generally will cover a condition if it hadn't led to treatment out to 2 years before you book your trip. And in other examples have specified 5 years or longer. So there is a great variation between what insurance companies offer, and you need to explore your different options. On the Choice website, it is a paid website, but you can pay just to explore the travel insurance guidelines. And it's something that the Australian government travel website would recommend for you to consider. Next slide, please. So give yourself enough time to not only plan, but to research. Apply for your travel insurance at least a month before you leave to find the best cover for you. Choice recommend getting at least 3 quotes because the responses from companies can vary considerably. So you must declare your existing medical condition or conditions, myeloma being one of them, and there are listed on their websites specifically what those conditions are, and you may have more than one. And then you need to answer an extra set of questions. Now, all companies provide an online questionnaire for you to do this, but people I've spoken to who've undergone this process actually find it's easier to ring and speak personally to a consultant who can help walk you through the form and the process and what type of answers are required. Just remember, if you're diagnosed with smoldering myeloma, emphasize that this has no symptoms, as we've heard in the previous talks, and no treatment. So therefore, it should not be considered a risk factor under this existing medical conditions. If your myeloma is less stable or you're planning to travel more than once a year, you can take out an annual insurance policy but upfront it'll be more expensive, but it might be more economical for you in the long run. Next slide, please. Sorry, I need the next slide now, thanks. Before you book online, it's a good idea to call that individual insurer and discuss how the policy works for your situation. And more recommendations from Choice is that if the online quote is out of your price range, just let them know that and explain. You might find that they are able to offer cover for you at a cheaper price. If not, Choice recommends or suggests declining the offer and that they may come back to you later with a better offer. And there are some testimonials to this on their website. It is recommended that if you have at least one travelling companion, should be insured on the same policy so that someone can accompany you home should you become unwell and covered under the same conditions that you've taken the insurance out. Next slide, please. If you're travelling with a wheelchair or mobility aid or other expensive medical equipment, you'll need to insure that as well. Apparently, in the fine print, many insurance companies don't cover hearing aids because they're so easily lost, and that you have to cover them as a separate policy as well. So just be aware of that. If you're unable to get cover for your pre-existing medical condition or the cost is prohibitive, as said before, you can still purchase a travel insurance policy. It just won't cover your myeloma. And interestingly, the Smart Traveller, which is the Australian government website research, has found that greater than 2 out of 3 people actually do travel without having insurance cover for their pre-existing medical conditions. Next slide, please. So now we're just going to look at some practical considerations about you, your myeloma, and your travel. Before you travel, check the government Smart Traveller website for travel advice, alerts, and warnings for your destinations on your itinerary. Subscribe to the Smart Traveller for updates about those destinations, and this will also register your travel plans with the Australian government. And download the Before You Go checklist to make sure that you have everything done prior to departure. Also, there's a area there where you can check restrictions on bringing certain drugs into your destination countries. You may need a letter of authorization for those drugs or equipment that you need to deliver them, such as syringes and needles. Next slide, please. Now, while you're away, carry your important documentations, your medical letters, and enough medicines equipment for a few days in your hand luggage. Because if your main luggage is lost or delayed, this will allow you a bit of wriggle room while you make alternate plans. Keep your medicines in their original packaging. Don't just download them put them into bottles or other containers for ease of packing, because they'll be confiscated at border checks. They must be labelled with their original labels from the pharmacy. And keep a list of all the medications that you're taking. It will help you if you need replacements. It'll also help you if you're seeking medical assistance while you're away. Take a thermometer and monitor your temperature if you're unwell. Use hand sanitizer and wipes regularly and wear a mask in public areas. We've all had plenty of practice with this during the COVID pandemic. So these are precautions that should be continued while you're travelling. We also recommend that you eat freshly prepared meals and avoid food from a buffet or a smorgasbord. These can be a source of infection for people who are immunocompromised, and even some of us who aren't. And please keep your medical receipts for your expenses so you can claim when you return from your holiday. Next slide. Thanks. There are some considerations to think about for flying. Will you be travelling alone or with a companion? Will you need assistance navigating through the airport or assistance with your baggage and boarding the aircraft? Will you be able to use the toilet on the plane or be able to hear or read the safety briefings and instructions from staff? Now, some airlines do have Braille version and large print version of their safety leaflets available. You'll need to request those. Next slide, thanks. So to address some of these points, under the disability access guidelines from the Australian government, airlines and airports have a responsibility to provide services for people with disability. Trained staff should be able to assist with getting around the airport, handling baggage, getting on and off the plane, and delivering safety briefings in a way that all passengers can understand. Opening packages and identifying food that's served on board the plane, and getting to and from the plane toilet. Now, they're notoriously small and cramped. If you feel that you may not be able to manage in the space that's provided, some airlines provide a privacy curtain that can be put up for you so that the door can be left open and you have a little bit more room to manoeuvre. There are certain things that under these regulations that the staff are not expected to assist you with, such as feeding, administering your medication, or actually using the toilet, or lifting a passenger and helping physically with their movement. So these are all things that you're entitled to request assistance with. Next slide, please. So some final thoughts I'd like to leave you with about the prospect of travelling. Now, you've worked really hard during your treatment to gain control of the myeloma and maximise your quality of life. So now's the time to do the things that you love to do. So whilst things have changed for you, there is your new normal, and travel is generally feasible. Embrace what you still love to do, including travel. Now, post-COVID, the world is opening up, but you may want advice on that. So please discuss that with your haematologist. Planning well is the key. It's an absolute key for an enjoyable and successful trip, and you'll never know where you'll end up travelling to. Next slide, please. This was taken pre-COVID, but who knows what's on the horizon. Next slide, please. So this ties in beautifully with our Joyful Moments campaign that you saw the video of earlier and that Hayley mentioned right up front at the start of today. Myeloma Australia wants to celebrate what makes you, you. We want to hear about all your hobbies and interests, and that includes your travel. We'd love you to send a photo or a video of you doing that thing that makes you feel joyful, or your travel photos, whether that's recently or still ahead of you. We'd like you to complete that sentence. I'm a 38 mate and I love, or I care for a 38 mate and I love, and email that with your photos and videos to us at 38mate@myeloma. And we'll share your photos and videos as part of our focus on this month's myeloma awareness of wellbeing and possibility. So thank you very much for listening, and I hope that's given you some inspiration to go travelling. Thank you. Bye.
Thank you so much, Jo. It's really exciting that we can start to think about travel as a possibility again. We have one question, or a couple of questions actually. First question is from Nicole. Is it possible to travel to Africa with yellow fever? Do you lose all vaccination protection after a stem cell transplant?
So off the top of my head, I'm not sure if yellow fever is a live vaccine or not. This is a specific question for your hematologist. But as far as the stem cell transplant goes, yes, you lose your vaccination memory. And that's why 6 months post-transplant, there's a full vaccination schedule that patients undergo to reinvigorate the memory of the common vaccines. But like all travellers to countries with high-risk diseases, you would need to have specific vaccinations and seek guidance from your hematologist on that.
Thanks, Jo. Second question is from Stephen. Can you please advise about safety on a plane? I've had a stem cell transplant 30 days ago and am flying in about 60 days. Masks worn on a plane. Any other suggestion for immunocompromised individuals on planes?
Well, all airlines still require you to wear masks. You may want to think about, if it's domestic travel, an upgrade to the front of the plane where there's a little bit more room. Obviously, that's a bigger cost if you're traveling overseas. Just make sure that you have a good fitting mask, an N95, that your vaccines are all up to date, that your COVID vaccines are up to date. Speak with your hematologist about what you should do if you're away and you suspect that you might have COVID. If you're in Australia, there are preventative or antiviral medications that can be given. You'll just need to know where you can access those in your destination. Overseas, this is an evolving area for us and we're learning as well. So you'll have to investigate that in the countries of your destination. So your travel agent might have more specific information about what's required in where the country that you're traveling to.
Yeah, COVID definitely adds that extra layer of planning and thought when we're traveling now. Well, thank you so much again, Jo, for joining us today. And as I said, very exciting to think about travel again after the last couple of years of lockdowns and the pandemic. So we'll now conclude our seminar for today. And I'd like to thank you again to all three of our speakers for taking time out of their weekend to present and share their expert knowledge with us. Thank you to all of you who have joined to watch this seminar live today, for those of you who have asked some really great questions, and also to those who are watching this back as a recording. Just a reminder to please fill out the evaluation form below on the website We really appreciate your feedback so we can continue to improve on our future seminars. We look forward to seeing all of your joyful moments, photos throughout May. And just a reminder for those of you in Queensland and New South Wales, if you do wish to join our rescheduled 3.8 with a mate walk on the 29th of May, you're able to register for that through our website. We hope you can join us for our next live seminar on Tuesday, the 17th of May at the same time as today's seminar. And we hope you enjoy the rest of your weekend. Take care.